Community is the way we find out.
All right, brief video showing the examples and things that we'll talk about a bit more.
Our strength and share our hope. It's the way dinner on the table brings the family.
We often picture students in a classroom or lecture hall, books open on their desk, listening intently to a teacher or professor in the front of the room. But in psychology, learning is something else. To psychologists, learning is a long-term change in behavior that's based on experience. Two of the main types of learning are called classical conditioning and operant, or instrumental conditioning. Let's talk about classical conditioning first. In the 1890s, a Russian physiologist named Ivan Pavlov was involved in this experiment on dogs. He showed dogs some food and rang a bell at the same time. After a while, the dogs would say the bell with food. They would learn that when they heard the bell, they would get fed. Eventually, just ringing the bell made the dog learn to accept food at the sound of a bell. You see, under normal conditions, sight and smell of food causes a dog to salivate. We call the food an unconditioned stimulus, and we call salivation an unconditioned response. Nobody trains a dog to salivate over some steak. However, when we pair an unconditioned stimulus like food with something that was previously neutral, like the sound of a bell, that neutral stimulus becomes a conditioned stimulus. And so classical conditioning was discovered. A few weeks later, this won't hurt a bit. Even though it won't hurt, you jump out of the chair and run screaming from the room. To get a shot, the words, "this won't hurt a bit," became a conditioned stimulus when they were paired with the pain of the shot, the unconditioned stimulus, which was followed by your conditioned response of getting the heck out of there. Classical conditioning in action. Operant conditioning explains how consequences lead to changes in voluntary behavior. So how does operant conditioning work? There are two main components in operant conditioning, reinforcement and punishment. Reinforcers make it more likely that you'll do something again, while punishers make it less likely. Reinforcement and punishment can be positive or negative, but this doesn't mean...
So it is worth noting here that reinforcement increases the likelihood of an event. Punishment decreases the likelihood of an event happening. The classic case is a child who screams hysterically in a store for candy, and you give them candy. Reinforcement, that's going to become important when we talk about why that could be.
Positive means the addition of a stimulus, like getting dessert after you finish your veggies, and negative means the removal of the stimulus, like getting a negative in your homework because you did well on an exam. Let's look at an example of operant conditioning. After eating dinner with your family, you clear the table and wash the dishes. When you're done, your mom gives you a big hug and says, "Thank you for helping me." In this situation, your mom's response is positive reinforcement if it makes you more likely to repeat the operant response, which is to clear the table and wash the dishes. Operant conditioning is everywhere in our daily lives. There aren't many things we do that haven't been influenced at some point by operant conditioning. We even see operant conditioning in some extraordinary situations. One group of scientists showed the power of operant conditioning by teaching pigeons to be art posters. Using food as a positive reinforcer, scientists have taught pigeons to select paintings by Monet over those by Picasso. When showed works of other artists, scientists observed stimulus generalization, as the pigeons chose the Impressionists over the Cubists. Maybe next they'll condition the pigeons to paint their own masterpieces.
All right, so let's talk through an example about conditioning. So let's take a case of a child cries for candy. Okay, child cries for candy. Parent gives candy. Okay. This leads to child crying again. This can be viewed in both ways. Because what's the outcome? Child cries, parent gives candy. Child gets candy. This is the outcome. So what happens is, this is a positive reinforcement for that to happen. The child cries, they get candy. Next time they're going to cry again. It was reinforced positively that they will get candy if they cry. So they will continue to cry and throw tantrums as so long as they get what they want. On the other hand, what happens to the child because they get candy? They stop crying. Right? Child stops crying. So what happens? This is now a negative reinforcement. Why is this a negative reinforcement? Because they removed something negative. Well, what's that going to encourage? It's going to encourage the child to cry again. And ultimately the parents to give them candy again to keep them quiet. So positive reinforcement is something that reinforces something by adding something, again, candy. Reinforcing behavior by removing something like the stressor of a child crying is negative reinforcement. Negative reinforcement is not punishment. Punishment is when something bad happens to decrease the likelihood of that behavior. So in the example, if you do the dishes every night, you don't have to take out the garbage. So by doing dishes, they don't do garbage. That's negative reinforcement. Versus if you don't do the dishes, you're going to get a slap across the back of your head. That's punishment. Important to know, don't go crazy over this. There's maybe one question about this topic. Just saying. The most important part of this chapter, after defense mechanisms, and again, I would encourage you, this is the time to get your flashcards out. One of the very few times, okay? It'd be 5 to 8 times that you need flashcards in this class. This number one was defense mechanisms. Second most important topic in this chapter is our friend Mr. Maslow. If you don't know Mr. Maslow by now, I'm sorry. But Mr. Maslow will become critically important over our period of time we have together. And for us, Maslow has really only two parts. That's all you need to know. Because no one else really remembers the in-between. For testing purposes, you just need to know the top and the bottom. And we're going to apply this from time to time. Anybody at the bottom? Remember what it is? Physiologic needs. Top one, self-actualization. Those are our two most important. I can't tell you for ATI or for other purposes. Well, for our class, the most important is self-actualization and physiologic. That will come up a lot when we start talking about our clinical disorders, particularly mood disorders and bipolar disorders. Those are your two most important things. So we talked a little about behavior. Most behavior is shaped through operant conditioning. We do more things if we are rewarded for them. It's human nature. And if we get punished for doing things, we typically don't do them as much. That's how we start to behave and act. The second part of this is how we think. And how we think it follows a very, very straightforward pathway, if you will. Sounds like a creaky old bed. When you have a stimulus, aka your phone vibrates, got a text message. You have one thing, and it's called an automatic thought. So the first way people think is called automatic thought. First thing that pops in your mind. Unadulterated. You see a text message, you're either like, oh great, let me look at it, or that person. You have that automatic response. Automatic. There's no thinking, no deliberation. It's the first thing that comes into your mind. And you have, in context, we're going to call them, we're not going to get into the actual number, we're going to call them deeper thoughts. These are subconscious. And those inform your automatic thoughts. Like for example, let's say you just had a fight with somebody and they text you. Your automatic thought is going to be, now that person again, because of what was going on beforehand. You have that automatic thought. Or if you really love someone deeply, you get excited by their text message. You don't consciously think about, oh, that's the love of my life. Lined up like a Christmas tree. No. We have these deeper thoughts. But those important automatic thoughts, these are what we focus on. What we will unfortunately see is some people act on this. An action is not good based on automatic. Or act on emotion without thinking. And then we have the set of things such as cognitive restructuring, coping skills, and other elements of probably problem solving. The things that we do after our automatic thoughts. The psychology here is that we cannot prevent our automatic thoughts from happening. They are what they are. Can't get rid of them. Some people tend to act based on their automatic thoughts and their automatic response. However, most people tend to go through these processes of coping or problem solving or doing cognitive restructuring. Cognitive restructuring is a very, very complicated term for thinking through. That's it. So for example, many people have a paranoid outlook. So for example, if your boss texts you, come see me tomorrow at 8 a.m. What's your first thing you're going to think about? I'm screwed. Pack my bags, go on Indeed, start applying for jobs. That's the automatic thought. Oh God, what did I do? Like, just like if I see a text message throughout the day from somebody, like from Sarah or Diane, like, oh God, what did I do now? What did I forget to do? Whatever. That's the automatic thought. But when you think about, well, how many times, and you don't have to answer this question, how many times has your boss called you into the office for absolutely nothing? So when you think about it, you're like, it's probably nothing, it's no big deal, they probably want this or this or this. That's cognitive restructuring. Or you problem solve. There's only one way to problem solve that situation. Anybody? Ask them what do you need about. My boss is a baby boomer, and she is classic, always triggering my millennial anxiety. She loves, no, she just loves to have her secretary schedule meetings that just say, catch up. And for like 3 days later, like, what the hell are we catching up on? Right, then, and now luckily your secretary, not schedule unless you know what it's about. But that's because automatic thoughts are so toxic and paranoid by nature. So I give you an example of that when I text my peeps at work. One of my direct reports, I text, hey, you got a minute, nothing bad. Take that kind of down. But if I texted her, a younger millennial, and said, can we talk? So why are we talking about this? Number one is how our mind works and how patients' minds work in the healthiest of ways. Automatic thoughts are generally negative, leaning towards paranoid, and when we act based on those automatic thoughts, bad things happen. Our goal is to work with patients to move past those automatic thoughts, to perform these skills, to think them in the best way possible. Is it always easy? Absolutely not. Is it mission critical? Absolutely. Speak of the devil. Teaching. All right, skip it around to the really important things. Problem solving is the most important thing that we can do. We're going to talk a lot about problem solving in subsequent chapters. Psychotherapy helps with the notion of how people think and behave. Most of the time we combine cognitive therapy, how we get people to think in a different way, with behavioral therapy, how people behave differently, and combining them into cognitive behavioral therapy. You often can't divorce the two. So for example, if you have someone with a bipolar disorder who doesn't take their medications and does things that are reckless, you have to combine the cognitive part, for example, the importance of medication, with the behavioral stuff of getting into routine with the medication is taken. We'll talk about, as time goes on, the difference between individual therapy, which is working on the individual, obviously, to then group therapy. And group therapy takes the place of different ways, but there's a difference between the general self-help style groups versus true group therapy. We differentiate them quickly. Self-help groups, or what we call individual therapeutic groups, or just therapeutic groups, are where each individual member of that group benefits independently of each other. Think of AA. AA is a classic example of a therapeutic group, not group therapy. A therapeutic group is where each individual benefits on their own. Everyone in AA benefits independently. Okay? If this class is a group, you all benefit individually from being here, ultimately being able to take exams, take your class and be a nurse. It is a therapeutic group you all individually benefit. Group therapy is where the group and its interrelationship benefits from the therapy. The goal is not individual, it is that group. The most common therapy that's group is marriage counseling. Marriage counseling is about the relationship and that group of people together, not the husband, not the wife, or not the two wives, not the spouses. Just like family therapy. People can have individual therapy, but family therapy is a group therapy where the benefit is for that family composition, not the individuals in therapy itself. To further differentiate, let's say you have a husband and wife going to marriage counseling. Husband has anger issues. For them to say, well, you husband need to work on your therapy or your anger issues, it's problematic, let's talk about how you are the problem. Group therapy is a conversation about your anger challenges are causing a disruption of the group. How can your spouse, your wife, help you so you can come together back into that group or that marriage? Slight difference, but it's ultimately who is aimed to benefit. If the individual is the sole beneficiary of the group, it is a therapeutic group. If the group is meant to benefit from the therapy as a whole, then that's group therapy. The last component of this chapter, we'll pause on electrical therapy and breathing and ECT. These are the somatic treatments. These are things that are non-pharmacologic. The things that we can do to the body or with the body that help improve psychological functioning. And so we're going to talk about pharmacotherapy or pharmacology next week. It's one of the mainstays of treatment. You learned that with Dawn and the young Vermont terms. There are some other ones we're going to talk about from time to time, like phototherapy. We'll talk about that. Seasonal affective disorder. But the two that we're going to focus on now for the first exam are biofeedback and electrical therapy. Biofeedback is a self-awareness of how one responds to stress and distress and acts appropriately. We're going to do a little biofeedback together. I'll show you how simple biofeedback is. Let's say I said, at 7:10, a random 3 of you have to come up and do a presentation in front of us. Presenting can be anxiety producing. So if you're up in front of the room, growing anxious about what you have to present, here's how biofeedback works. Question number 1 is, what's the symptom that we're focusing on? Anxiety. Okay. Question number 2 is, how do you know you're getting anxious? And there's not going to be a uniform answer. Each of you will have your own answer. So if you think about, okay, I'm up in the front of the room, I don't want to get anxious. I know I'm getting anxious when blank. It could be your palms get sweaty. It could feel like you get some restless light moving around. It could be getting a little bit dizzy. It could be that your heart starts to pound. Could be a bunch of things. So that's step 2. Step 1 is we know what the emotion is. Number 2, we know when that emotion is starting to come up. How we feel that emotion. Step 3 in biofeedback is what can you do to stop that emotion? So biofeedback is recognizing that one's body is getting emotional and knowing what to do when those emotions start. So you may not, this may surprise you, I don't like public speaking. I really don't. This is not to me public speaking. Like, give me an audience with like 200 people. And I'm a good example of problem-focused code. If I have to present, I rehearse it 100 times over to where I know exactly what I'm going to say. Ask me a question during the middle of my presentation, I will kill you. Throw me off, don't do it. But if I'm standing at the lecture, a podium lecture, if I'm standing at a lecture, what's your SAT word of the day? This is a lecture, not the podium. If I'm standing getting ready to talk, I know my bum starts to get sweaty and I'm getting nervous. So what happens once you realize you're getting nervous? You get more nervous. So I know when I get nervous what I need to do. I use mindfulness. Mindfulness is one of the strongest interventions to combat anxiety. Anybody know what mindfulness is? Mindfulness is being aware of the exact situation you are in. And the notion is, if you become mindful, always all the anxiety goes down. And there's 2 ways that are very easy to practice mindfulness. And this is how biofeedback works. You're up here, you're getting anxious, you know you're getting anxious, you do something like mindfulness to start. Number 1 is people tend to pick cuticles or harm themselves in some other way. That's why you see people like going like this while they're up, because cracking their knuckles. Why? Because they're focusing on the tactile. That helps distract from the emotion. So one thing that people can do is to distract is use the typical thing like this, and then do some like patterns. Or you distract yourself. So mindfulness can also be distraction. This is where they tell you to picture the audience naked. You ever heard that phrase before? It doesn't work. We know it doesn't work. I'll tell you how to make it work though. We're on trend with sex tonight. The way that the only real way to have that notion work is pick someone and stare at them with googly eyes and picture them naked. That is the way it works. Because it focuses someone's attention and you get involved in that person and the undressing of that person. So when you forget you're on the stage until you're like, oh, wait, let's go. Now, a more appropriate way is to focus on something tangible and start describing it in depth or trying to understand it in depth. And that self-talk can help to distract. So I can give an example if I was to do that, if I was like getting nervous. I would typically look at water bottles. That's my thing. So for example, Owalas, I'd be looking at the colorways and trying to see how different it is from my kids. Is that the 24 or the 32? I think it's the 24. It's like 24. That looks like the 24. That's a weird one. What's that one? I wonder if it has a straw and you can drink like the other ones. It's a weird. So again, my mind is going down a rabbit hole about water bottles. Is it relevant to anything? No, but it's taking me away from the emotion. Is it 32? Mm-hmm. That was just a weird one. Is that even in Walla?
Yes.
I was going to say it. It's weird. Is that like a 40-ounce one or something?
Yeah.
With a lot of problems. Okay, last topic, really quick video, electroconvulsive therapy, what people think is amazing, but it's really boring. Everyone's like, ooh, electroconvulsive therapy, that's boring.
You're just shocked right now.
Quick video. I'm going to use this video to more explain what ECT is than actually educational.
Electroconvulsive therapy.
So I'll tell you, electroconvulsive therapy is one of my favorite stories. I probably have given this story before about how they did this in medical ethics, where they started zapping people and they're like, okay, this works. We don't really know why electroconvulsive therapy works, but it does. It involves electrodes being placed, you'll see what some of this is, on a person's head. A person is paralyzed and sedated, and then a grand mal seizure is induced for a very short period of time. And that seizure tends to dramatically improve mood over a period of time. So the typical questions that we see on whether it's ATI or end collective eye exam is what is electroconvulsive therapy and some key teaching points. And I'm going to tell you there's probably 3 or 4 things you need to know. One is electroconvulsive therapy is a procedure and requires informed consent. And so informed consent responsibility to obtain informed consent. Number 2 is we are sedating and paralyzing a patient. What should we be most concerned about in terms of our basic things? Your airway, and their breathing and making sure that that is fine. Usually there is a nasal trumpet or some sort of artificial airway put in. They're not completely sedated, technically. And then post-procedure, patients are typically coming out of sedation. They also just have seizure. And there are 2 consideration points. Number 1 is that patients are generally at risk of fall after electroconvulsive therapy. Number 2 is that They may have some short-term memory loss. Long-term memory loss is unheard of. But there may be some short-term memory loss. They can't really remember that morning or the previous day or so. And the number 3 thing is that you have to ensure that their gag reflex returns, which is general post-anesthesia care, prior to giving them full liquids. Like they have to try to drink a sip of water, make sure they get swallowed versus giving them of water. So this is a very quick video. As you can see, it's only about 2 minutes. Sort of walks through. It's a video from Western Virginia University that explains what ECT is for patients. But I felt it was a good intro for us.
Electroconvulsive therapy, or ECT, is often called a treatment of last resort for patients who haven't had success with drug therapies, who have life-threatening psychiatric conditions, or are suffering a catatonic state. ECT induces a brief seizure in a patient which resets the brain functions associated with some psychiatric disorders.
It's typically indicated for treatment-resistant psychiatric conditions, most commonly mood disorders or depression, but there are multiple types of depression, so it can also be used to treat bipolar depression.
The majority of ECT treatments are managed like outpatient procedures, and the patient is given general anesthesia.
When the patient's asleep, the stimulus is delivered, the seizure's monitored, they'll have just one seizure.
An electrical current is given low enough not to harm the patient, but high enough to trigger a seizure. The treatment team can even touch the patient.
The thing that concerns patients the most is that they know that they will be having a seizure. They're concerned about what may be happening while they're either asleep or while they're having that seizure. And thanks to the anesthetic, it's very hard to tell. In fact, the only way you can truly tell if they're having a seizure or not is to kind of monitor the motor activity and then monitor the EEG activity.
The patient awakens soon after and is monitored for a short while like any patient who has undergone general anesthesia. Within a half hour, they'll be discharged. In some cases, a handful of ECT treatments may be all that's needed to make medication therapy work. For other patients, regular recurring ECT treatments may be needed. In Morgantown for the WVU Health Report, I'm Dr. Wallace Sullivan.
Electroconvulsive therapy fell out of favor years ago. Prior to the introductions of paralytics. So back in the day, we used to just shock people thoroughly, and they'd have a seizure, break bones, whatever else. And that fell out of vogue. But with the advent of anesthesia and paralytics, it's come back. One thing that I disagree with the video on is the video says it's a last resort. I don't think that's true at all. In some cases, it's the first treatment. And so the idea is, it used to be that you had to have 3 failed medication trials. And each medication trial had to last, say, 3 months. So 9-month delay. That to me is too long to have somebody miserable. If you have someone deeply, deeply depressed, it's often better to intervene with electroconvulsive therapy, break that severe depression, and get them moving again. The next chapter is going to be fairly brief. Complementary and alternative therapies. I'm going to try and get through it. Let me just see. Yeah, we got to get through this chapter, or we're going to start being behind. I'm going to give you the very brief of what you need to know. Complementary treatment works with traditional Western medicine or allopathic medicine. Alternative medicine is in place of allopathic treatment. So an example is someone who takes multivitamins or something like that. Complementary. Alternative is where a supplement or therapy is treatment, like an herbal treatment, is used in place of conventional treatment. Either way, and the rest of the chapter you can read if you want to, but just fast forward with the key points you need to know. Number one is either one of these is fine. Patients have the right to choose. However, point number one is we must remember as nurses to ask about herbals and other supplements. People don't like to talk about it. So if folks are taking herbals such as St. John's wort, they may not be forthcoming to tell somebody they're taking. So it's critically important that we ask people about complementary and alternative medications that they're taking. Number two is that alternative medications are completely unregulated. That health food store, health food aisle at Stop and Shop, completely unregulated. All those pills with all these funky things, completely unregulated. The very most important one to know is, excuse me, St. John's wort. Remember what St. John's wort is for? Depression. And it's been shown to be as effective as an SSRI. As effective. Good doctors, like go counter SSRI. I think they're going to make Lexapro or one of those guys over the counter.
They should.
I think it's already in the water.
Yeah, it would make people happier.
Everybody, yeah, the world would be a better place if everyone was on the out.
Mm-hmm.
It's my hot take for that. The concern with St. John's wort is terrible. It works, but it interacts with almost everything. Its interaction list is probably the most of any drug. And so we have a combination of people who typically don't disclose herbal treatments at baseline on an herbal that interacts with everything that you can order 1 billion of on Amazon. It's typically more of a problem than it is beneficial. So that's that. We'll talk about anything else later. Let's go on break. Get back. We'll try and get through chapter 8 and 9. Pharmacology is next week. We probably can buffer some of what we can do over with that chapter. But we'll see what we get to.